do a quick introduction of who's here at the table, and then we'll start our presentation. And we're going to start with Andrew.
Andrew, my third year.
I'm Debbie Dellman. I'm also a third-year medical student.
Edward Wagner, third-year medical student at Christian.
Ryan Moore, third year, medical student, Christian.
Ryan Pappas, fourth-year medical student.
Christine Wilson, third-year medical student.
Justin Green, third-year medical student. Alex Meyer, third-year medical student.
Hassan Kimmich, third year.
Adam Kennedy, third year.
Abby Moore, third year. Joanne Young, third year.
Lindsay Alex, third year.
Alex Gordon, third year.
Dr. Perry, I'm the dean at Christian in St. Louis. Woo! So we're going to go ahead with our Christian Hospital Readmission Improvement Project. So I will hand it over to Ryan and Christine.
Okay, so last year as a third year, Dr. Perry kind of approached us with the possible team steps. Probably we would take on it to receive honors credit. And she kind of informed us about the something that's been going on in medicine called the Medicare Reform Act. It's actually the 2010 Patient Protection and Affordable Care Act. This goal was to transform Medicare from a passive payer to an active purchaser of higher quality, more efficient health care. This new program was actually started in fiscal year 2013, which is the fall 2012. So, why even focus on this? Why is this even important? When patients are readmitted, this is considered by many to be a marker of poor quality care, wasted revenue, and inefficient use of resources. And the CMS has concluded that 2/3 of all readmissions are actually avoidable. So again, why is this important? Well, Medicare is spending an additional $15 billion a year on readmissions. They also estimate that about 12.5% of Medicare heart failure admissions were followed by a readmission within 15 days, accounting for more than 90,000 admissions at a cost of $590 million. And then all-cause 30-day readmission rates per 1,000 patients discharged with heart failure increased by 11% between 1992 and 2001. So that's a lot of money that's being funneled out. So beginning in October 2012, fiscal year 2013, this program incentivizes quality improvement in 3 conditions, having highest volumes of readmissions. So every hospital across the nation with a higher than expected risk-adjusted 30-day readmissions rate receive reduction in all base DRG payments, which basically just payments out. And then beginning in fiscal year 2015, 4 new conditions have been added. And so this expanded the list to CHF, acute myocardial infarction, community-acquired pneumonia, and COPD. So beginning in fiscal year 2013, the maximum financial impact across all BJC hospitals, the St. Louis area, is approximately $4.5 million, and this is expected to only increase in coming years.
I just want to make one point. The CMS maximum penalty is applied to all conditions, not just CHF, COPD, pneumonia, AMI. So it's every single payment on every single patient. So that's why it's such a huge amount of money. And none of the hospitals, we're running barely positive right now, so we can't afford to have this type of penalty.
So this readmission drivers can kind of be broken down into the population perspective and clinical perspective. Regarding the population perspective, we try to focus on the patient and their environments. And from our side, the clinical perspective, we also have to focus on the patient, but also the encounter, what we're actually doing, and all the support staff and the organization within the hospital. So readmissions drivers was kind of been found to have some consistent evidence to support these drivers is older age, people with poor activities of daily living, poor self-rated health, high levels of comorbidity and severity of illnesses, any clinical complications that arise during the hospitalization, a history of frequent hospitalizations, and also any patients that leave the hospital and get medical advice.
Which we are also penalized for, so if they leave against their own choosing, we still get penalized if they get readmitted.
So other drivers that are kind of controversial, and there's kind of inconsistent evidence to support these issues is like minority race and ethnicity, low socioeconomic status, poor education, no high school diploma, people who are unemployed or not currently working, and then also insurance. There's inconsistent evidence showing that there's a difference between public Medicare versus Medicaid versus private insurance as well. So here's just a quick example of CHF 30-day heart failure readmission rate by EJC hospitals. So right here in blue arrow, that's us, Christian Hospital. We were at 26.8%. The U.S. rate, the average is about 24.8%. Barnes Jewish Hospital, the main hospital here, is 28.4%. So as you can see, we're about 2% above the national average.
And also, Christian has the most ED visits out of all these hospitals at 112,000. So even though BJH has more hospital beds, we actually see more patients coming back for readmissions, or pretty close. Our volume is very, very close. We have more patients than BJH, but yet we're a little bit down, so we're doing a little bit better than them. But still, it's terrible. But this is, 7 to 10, so.
Here's it's kind of the same graph for AMI, and again, we're still pretty terrible, 22.3% above the U.S. national average of 19.8%. So even though it's only 2 or 3% difference, that's a lot of money compared to, again, the guess here, 18.5%, that's a lot of money. And here, the same chart for community-acquired pneumonia, and again, we're above the national average, 20.8%, Barnes Jewish, 22.9%. And this is kind of a busy slide, but really, kind of the accounting department presented with us. This bottom figure, this red bolded figure, $487,000 is the estimated impact that these readmissions will have of the fiscal year 2013. And so when hospitals are just barely running above red, and to have something like that lose kind of funneled out is a huge issue.
Yeah, parentheses are not good under round numbers.
So Christian Hospital has kind of implemented some goals. So kind of on a step-by-step basis, reduce AMI and CHF readmissions by 20% from their baseline. So the end goal is to have a 15.7% baseline for AMI and 21.6% for CHF. Excuse me, that's their baseline. Our goal is 12.5%, and the CHF goal is 17.2%. So this was implemented starting in February 2011. Kind of we wanted to focus on all payer patient populations. We wanted to exclude patients from extended care facilities and rehab, and just have a mix of evidence-based models. And so, when a patient comes in, we kind of just can organize them in a couple different parts. First, in the initial assessment, PES identifies admitted at-risk patients, and these are patients with a history of acute MI, a heart failure that have been discharged in the previous 90 days. In the ER, any likely AMI patients, these are assessed using elevated troponins and whatnot. Case management basically risk stratifies these likely patients, and these high-risk patients, this list is pushed to nursing, dietary, and pharmacy departments. And then once they're admitted into the hospital, there's a couple other procedures that happen. Nursing provides basic education for risk level 1 and 2 patients. Pharmacy and dietary also meet with the patient and provide education. And case management, importantly, schedules post-discharge physician visits. And then also for post-discharge interventions, home health visits are arranged for level 2 patients, and there's also what we have an EJC call center, which contacts patients post-discharge and checks on them and makes sure they got their medications, are going to the doctor's appointments, they understand everything. So, and this is just an example of a diagnostic tool for a 30-day readmission. So let me So here, this is an important chart as well. Basically, what we were weakening as far as implementing these measures was physician visits within 7 days post-discharge. You know, ideally, you want the patient, like a CHF patient, for example, to see a doctor within 7 days after they've been discharged. And here we can see really our rate was 10.9% of patients getting a doctor's appointment within 7 days. We also, any home health visits, we were only at 54.3%, and any type of care provider that the patient saw was a nursing doctor was 60.9%. So again, these are already high-risk patients, perhaps CHF, COPD, whatnot. And for instance, for the physician visits, only 10% of these patients are getting doctor's appointments within a week or so. So then here's a breakdown of readmission rates within 7 days. And this just shows the significance of post-discharge physician visits within 7 days of discharge, which is a nice graph to show kind of what's happening here. And so, this is a pretty big project, and so there's a lot of challenges here. First up, the physician engagement in the process. Physicians need to be aware that these patients are at risk. They have to have active support processes. These patients need to be provided with proper education, also made a doctor's appointment within a week, and also have home health visit orders. And these doctors should also share performance accountability with everybody else. And then staffing resources and commitments. It's a tough, every hospital is short-staffed on the weekend. You have competing priorities, and as of before, there were no really dedicated resources to address this problem. And so that's what we're kind of doing, is kind of working towards a more dedicated coverage of the actual readmissions team to solely address this problem and hopefully fill in the gaps. And we also have a problem with effective patient engagement. When you talk to an average patient about CHF, it seems pretty simple to us, but to the layperson, it's probably pretty confusing. And patients like COPD, I've seen a lot of patients who can't even use their inhalers correctly. So just kind of breaking it down very simply and ensure that patients understand why they're taking this medicine, which symptoms to look out for, the importance of follow-up with doctors. That's kind of a key to this whole process. And then compliance too. You can only do so much, but you have to ensure that patients are compliant with their care. So this project we kind of created was to identify readmits on arrival in ED. Identify patients for appropriate admissions with a 24-hour observation versus inpatient status. The important thing about 24-hour observation is that this doesn't count against readmissions. Unless I'm wrong, right? But is that correct?
That's right.
Yeah. So somebody with community-acquired pneumonia, if they're not looking too sickly, 24-hour admit them versus a full inpatient admit. It's a case-by-case basis, but that would save a lot of money. And then also support physician patient engagement gaps. So again, keep up with patient education, convey to the patient the significance and the importance of home health and physician follow-ups, and make sure these patients are compliant with their care plan. And Christine now will kind of talk about the next steps that the current 30 years took over to continue this project.
Alrighty, thank you. So we kind of stepped in this year and just kind of got more active in the project and actually going to see the patients after they kind of built this wonderful basis for us to go on. So we had the same goal. We wanted to decrease the number of patients that ended up returning to the hospital within 30 days of a previous discharge. And so our plan was to actually extend that and see patients that came in within 90 days, not just at 30 days. And following some of the team steps principles, we really wanted to incorporate patients into their own healthcare and make them a member of the healthcare team. We worked to educate the patients and also, like Ryan said, to help facilitate some of the post-discharge care compliance. So our action plan, on the first day, several different members of the healthcare team would go and see them. They'd speak with the dietitian, they'd speak with their social worker, someone from pharmacy would go and speak with them, and then obviously their case manager would be in contact. And they would just kind of educate the patient, help them facilitate anything they need after their discharge from the hospital. And then on the second day, the students will go in and talk with them and kind of make sure everything happened on the first day that was supposed to, provide further education if necessary. And then once they left, we also followed up with the patients and would check in with them and see how they were doing, if they were going to see their physician, if they were taking their medications, whatever it may be. So this was the checklist that we kind of followed when we would go and see a patient. Every day, a list is populated of patients that have been readmitted. We get one at 6:45 a.m. and another at 11:45 a.m. And for each month, we have one student who is kind of the team leader for that month, and they make sure that all the patients that readmitted in that month are seen. And students have just been volunteering on a daily basis to go and see those patients, and this is kind of the process that we follow. Once we get the patient's name, we look up all of their information. We read up on their previous admission histories, on their medications, any diagnoses they have, just to kind of familiarize ourselves with each individual patient. Then we go and talk with them, and we kind of cross-monitor to make sure that nutrition has seen them, that they understand any dietary modifications they need to follow, try to answer any questions they might have, and if they really didn't learn a whole lot from the first visit, we'll have nutrition come back and see them again. And then we kind of do a similar thing with pharmacy. Unfortunately, these are really complicated patients most of the time, and they have a huge list of medications. So we go over when to take the medications, why they're taking medications, just make sure they really understand what they're doing there, and answer questions again. And then we also make sure that they do have that cardiology or primary care physician visit scheduled within that really important 7-day window. We review with them when they need to call 911, what truly facilitates or what truly counts for an emergency. And we also get a good contact number and figure out when's the best time of day to get in touch with them, so then we can follow up and make sure they're doing everything they possibly can to stay out of the hospital and prevent any disease progression. So just some of the different things that we do for patient education. We go over their medications, like I said, we go over their diet, changes in their lifestyle. We make sure that they fully understand the disease process of congestive heart failure. Again, like I said, we discuss what constitutes an emergency. We make sure they're aware of all the different resources the hospital provides. The home health program is amazing. They will send scales, blood pressure monitors, blood sugar monitors, whatever they might need into their homes, so we can kind of monitor the patient's status off-site. And then anything else, we've even had to call chancellors in for patients, whatever they may need to help them feel better. And like the check-back method we learned in the Team 6 project, we use a teach-back method at Christian, where we explain everything, and then we have the patient repeat it back to us to make sure that they have a good grasp on everything we've taught them. So here's just some of the patient information. We also give them this hard copy, just because it can be overwhelming, all the information that's thrown at them when they're in the hospital. So we got this up to date, some wonderful tools for patient information. Just goes over what heart failure is, what their different symptoms might be, things that they can do to prevent disease progression, like taking their medications, being acutely aware of the signs and symptoms they might have, and any changes in how they're feeling, keeping their doctor in the loop on everything, strictly adhering to their low sodium diet. A lot of patients seem to think if you're not pouring salt on your food, then you're following a low sodium diet. They're not really sure what it is to be on that low sodium diet, so you really have to talk to them about the specifics. And then just encourage overall good health, trying to lose weight, stop smoking, limit their alcohol, change their lifestyle a little bit, and always keep your doctor informed. So we developed an action plan that they can kind of follow to let them know when they need to take action. If they're having changes in their breathing, changes in their weight, if they're retaining fluids, having any swelling, or if they're changing in their ability to do day-to-day activities. So if it's just the moderate changes, they're not really having chest pain or trouble breathing, just keep adhering to your medical care plan, take your medicines, weigh yourself daily, follow your diet and lifestyle modifications. just to kind of be aware if you're having trouble breathing when you're sleeping and find yourself propping yourself up with more pillows, or if you gain around 2 to 3 pounds overnight, you might want to let your doctor know. You might not necessarily need to go into the office, but just keep them informed and they can maybe make a slight change in your healthcare plan. And then more severe symptoms, if they are having trouble breathing, if they're coughing more, if they're gaining more than 5 pounds overnight, get in to see your doctor immediately, and hopefully they can prevent you from decompensating so bad that you need to go back into the hospital. And then obviously if they're having really difficulty breathing, if they're becoming cyanotic, if they're having altered mental status, or if they're losing consciousness, they need to get into the emergency room immediately. So just some things that we've kind of noticed in working with this in the last year. There's a lot of different reasons that we get from the patients as to why they're coming back. But the number one thing we're seeing is patients coming back into the hospital that aren't there for their congestive heart failure in the first place. They're there for pneumonia or some other cause that's bringing them back in. Also, non-compliance is a huge problem, and it's a wide variety of things they're being non-compliant with. Medication is probably a big one. A lot of patients in our demographics can't seem to afford their medications, and they'll selectively at random pick which ones to go ahead and pay for and follow with, not changing their diet or their lifestyles. And unfortunately, we do have some patients that are just kind of indifferent and think they're doing okay, so they don't really want to change anything. There's also a lack of follow-up care. It can be pretty difficult to get a patient in to see a cardiologist to squeeze them in a 7-day time period, so we're trying to work around that. And then also just overall poor healthcare team coordination. So they have been collecting data still at the hospital. It's pretty early to be making any conclusions from it, but it is kind of encouraging because what we're seeing is in the last 6-month rolling period, since we've been seeing patients starting in September, they actually have had a decrease in their average readmission rate at the hospital. If it continues on this trajectory, it'll put us about a 19%, so we're getting a lot closer to that 17% we're aiming for. So hopefully this continues, and hopefully it really is something that the students and the hospital's action plan are having an effect on. So I'm going to let Brian speak a little bit about some of the challenges and the rewards that we've faced with this project.
So we've coming on board as students into a big health system that's trying to address a big $100,000, maybe even $1 million shortfall with this. We've had some uphill kind of battles, and the hospital's been working on a lot of things. One big problem we've had is this is also new, and we're a hospital that has a big part of the problem, but we're part of a system that's got a big problem, and finding a good communication between our BJC parent and the hospital, and finding, that, yeah, we can use some of their resources and some of their ideas from other hospitals, but that won't always apply to our patient base. We've also had some bureaucracy type issues where there's too many hands in the pot, and too many people are trying to fix the problem from their approach, or think that their approach is going to fix it. And what it's led to is a problem with communicating with the patients. We were going and asking patients questions, the nurse was, the case manager, the social worker, and the patients got confused. They thought that maybe they had already told us one thing when they actually told someone else, or vice versa, and it led to some shortcomings and just holes in the process. The group, several of us went to what's called the Rapid Improvement event, where we all sat in a room together and kind of talked from our perspective about how to fix this problem. And what came out of it is a navigator role, which will be a social worker, case manager, nurse practitioner. There's several people that are going to be employed with the sole focus of improving these readmissions. They will be kind of like the quarterback for everyone that's involved with the readmissions, and the hope is that will help improve communication, not just with patients, but also with the different providers, so that pharmacy knows what case management is telling the patients. And where we fit into this process is that the students will come in 2 days later and do the teach-back method to make sure that the patients understand it. And hopefully by doing that, the patients become more compliant and better in control of their own health. Also, in terms of the patient follow-up, that's been a big struggle that we've had, and it came out a lot during this rapid improvement event, that patients aren't getting appointments within 7 days for follow-up care. And in meeting with some administrators, what we found out is that the physicians don't have a lot of, they don't have anything to gain, in their opinion. What we found out statistically is that to kind of reach our goal, they only need to improve our readmissions or reduce our readmissions by maybe 10 or 12 patients a year. And when you're asking 30, 40 family physicians to change the whole way that they practice medicine, just to impact 10 or 12 patients a year across the whole system, not just across their practice, but the whole system, that's a lot to ask for not a whole lot in return. In the future, the thought is that there will be some financial impact and burden placed on the primary care providers, and the hope is that once they feel the heat from all these changes, that they will come more on board. I've noticed, and I know several of us have noticed, that as we've become more aware and more involved in this process, some of the physicians that we've worked with have become more aware of the problem and have taken a more proactive approach to helping with this. But through this navigator role and through more physician involvement, we hope to improve communication and improve follow-up and lead to some of these rewards, like the disease course education, the health maintenance education, the healthcare policy awareness among the whole group within BJC and Christian Hospital, and awareness of these social issues that prevent our patients from having the best control of their health.
So as Brian was kind of saying, there's a lot of planning going on to expand this current project. In the immediate future, like you said, they're hiring a health team transition coach. They're discussing bringing in a nurse practitioner to help with follow-up care visits if the patients can't get in to see their cardiologist or primary care physician within that 7 to 14 day time frame. And they have updated the student checklist for when we go and speak with the patients. They've really emphasized the assessment of the previous hospitalization. We're going to be talking with the providers, and we're going to be helping to develop an action plan to prevent readmission. So just quickly going through this new updated list. Like I said, we're going to be talking with the patient to see if they did follow up with their physician, if they use the resources the hospital provides, like home health care, if they have an advanced directive in place. And then we're going to be assessing to make sure that all the steps happened with their previous admission if they saw everyone from the healthcare team they were supposed to. We'll be calling their primary care providers or their cardiologists and see what that physician thinks is the cause for their readmission and if they think that it could have been prevented. We're going to still be talking with the patient or their caregiver to see what their impression is of what they thought brought them back into the hospital, and asking if they really understood what they needed to do once they got out of the hospital. And then, like I said, we're going to be making our own assessment if it was a patient issue, if it was a care planning problem, if it was just a medical management error. And then we're going to be recommending actions to take in the future to help reduce the readmissions. And as this whole project expands, the hospital is wanting to include more diagnoses, including COPD, pneumonia, asthma, heart attacks, diabetes, and then a big future goal is to develop a medical institute that can really be there for patients who don't always have the best access to healthcare. We'll be providing all sorts of daily care, point-of-care testing for their blood sugar, their blood pressure, diabetes education, asthma education, and smoking cessation classes. So that's pretty much where we are in the project right now. Are there any questions or anything?
No questions? Hello?
I'm listening.
Put your Johnny Johns down and ask a question. Trey.
Hey, can you guys hear me? This is Joe from Springfield.
Yeah.
Yes.
I got a quick question regarding, I may have missed this, but you guys actually have call centers that contact the patients post-discharge, as well as you guys are volunteering time to contact these patients? Is that correct?
Yeah, the hope is in the future that the call center will be more involved in this. the students were kind of just going ahead and putting the plan into action before the hospital had their big definitive setup going. The hospital's hoping to kind of go live in the next couple of months with this larger action plan they have. But right now, we're still contacting the patients, but in the future, it'll just be the call center.
Okay, now, are there already measures of success for this call center, or is that something that's going to be kind of in flux as once the call center is kind of up and going, and they're going to determine what their measures of success are going to be?
I think that they're going to be measuring that more in the future. In meeting with some of the hospital administrators, what they're kind of telling us is that they're really wanting to get a plan on the ground and going before they start, collecting data with with demographics, anything that might be going on. But right now, they just kind of wanted to put a Band-Aid on the problem and fix as much of it as we can before they go forward and really develop more.
The reason I'm asking,
I just wanted to say that the students here in St. Louis did visit the call center to see what they did, because I don't think they were quite sure on how this all worked. But there are nurses at the call center, there are secretaries to make appointments, there's telemetry monitoring for blood pressure, weight, blood sugars, etc., all in this one call center that we're very fortunate to have. They will be doing some, obviously we'll be measuring the success of the call center, but they are just starting, so I don't even have baseline right now. So hopefully in the next couple months we'll have baseline, and then we'll set a goal, and then we'll measure that, and by the end of the year we should have some definite data to see how it's working. Did that help?
oh yeah, I mean, it sounds like it's a great initiative. One of the things I'm kind of seeing is not only at the primary care office, but especially in the nursing homes, there's a lot of misinformation, or just the information is not getting sent from the hospitals over to the nursing, especially the nursing facilities. So this call center would be great, not only to, I don't know if it's possible, but not only to contact the patients, but maybe even, for example, if they're going to a nursing care facility, to contact that facility as well, to make sure that they're getting the information they need, at the nursing home. So it's a fantastic program, and hopefully we'll see those go up throughout all the systems.
I just want to let you know that we haven't been focusing on extended care facility patients. So that is not a major driver that we're looking at right now. However, with myself in the emergency department, since I'm the chief of emergency medicine, we are trying to go out, reach out to the nursing homes with our own case management, and trying to make sure that they get the best information possible if they do get discharged from the ED or eventually from the floor. So case management and the transitional health coach will work with the extended care facility patients, but the students are really focusing on those who are going home or to assisted living, those types of places. That's our highest risk for readmission. Any other questions?
This is Janet Head.
What are you all doing for readmissions?
Okay, you're unmuted now,
Do you guys have any comments about readmission stuff? Okay. This is Janet Head in Kirksville, and I want to thank you, Dr. Perry, and your student team for taking on this project as a Team Steps Honors Project. Good going. And also very much for reporting on it. I think it's really exciting. So hope to see other sites picking up things like that. So if there are any other questions, we have here in Kirksville an Evolving Pathways project that is looking at post-hospital exercise and nutrition issues, and so we're kind of working on it a little bit, but really excited about what you guys are doing and how you all are doing it. So.
And if anybody needs help implementing it into their sites, we'd be happy to help out, or I could be contacted and we can talk about it, even if it's just one small portion of the project and not the whole major thing. We have a lot of support, and our administration has been very supportive of the students and have put a lot of time and effort and listened to them, which is pretty impressive. And so we're very lucky, but if anybody else needs help in doing it, if they're interested in it, they can contact me and we can go over it.
I was looking at some of your patient education materials and outlines and protocols and algorithms as you went through, and you've done a great job on that, and certainly hope you would be willing to share. So.
The presentation today, if you want to borrow it and put your own title on it, that's fine with us.
I heard the phrase rob and deploy yesterday, I think, in a presentation, so we'll look at that.
Please do.
All right, thanks.
Peace.
I don't see any questions here. I'm not sure who else is on. Southwest, Southeast, St. Joan. Thank you guys very much.
Well, I'm going to take my students out to lunch.
Such a deal. Way to go. All right.